we are live. Good morning, everyone, wherever you are tuning in from. Welcome, this is Patrick. We're very happy to have Dr. Flowers with us. Today's topic is a guide to keeping your heart healthy, and it's with the hopes you'll be able to apply this knowledge to improve your health, your well-being, or maybe even some information that you can share with your loved ones. If you have any questions for Dr. Flowers, please save them for the end of the talk, and I'll make sure each and every one of you will be able to have the opportunity. With that said, Dr. Flowers, take it away.
Thanks, everybody, for coming today. This is a topic of great interest, especially for those of us at Cenegenics when we're looking at optimizing health and wellness. And we're going to go through some things that talk about the importance of keeping your heart healthy, how we do that, and how we can be more proactive in how we approach this and be effective in doing this to keep you healthy and well and prevent this from happening. So we're going to talk about the importance of heart disease in this country and just to the level that it is throughout the population, and the importance of that just because of the risks that occur to us as far as morbidity and mortality. And how do we identify this early? And this is really the key for this. So prevention is the key to controlling this disease much better than the treatments on the back end. How do we decrease your chances of actually having that heart attack or stroke? And then we'll talk about our interventional preventive medicine approach with Cenegenics. Heart disease is still the #1 killer in the U.S. So whether people worry about cancers or other diseases, this is still the #1 killer in the United States and actually globally. So the prevalence in the population, about 3% of the population are dealing with this. There are about 750,000 new heart attacks every year, and then about another 1/3 recurrent heart attacks every year. Now, the average onset for the first heart attack for males is about 65 and about 72 for females. But this is actually being called into question with some new data that's come out this year that I'll share with you. Worldwide, 1/3 of all deaths are related to cardiovascular disease. So what is coronary artery disease? What's happening here? We're actually narrowing the arteries that supply blood and oxygen and nutrients to the cardiac tissue. And it's more than just cholesterol. So that is a big focus in medical care today. And this process of coronary artery disease is a multifactorial process that involves dysfunction of the vasculature, inflammation, and then there's an intense immune reaction that's happening interacting with the cholesterol. So it's not simply the presence of cholesterol itself, it's actually what is happening in our blood vessels itself. Atherosclerosis can occur in the heart and the brain, or any blood vessel. Today's focus is going to be looking at what happens with the coronary artery disease. As it becomes more and more severe, sometimes people are unaware of that. In fact, 40 to 60% of the first indication of atherosclerotic disease is actually acute myocardial infarction or sudden death. So we want to understand why are we at risk or who is at risk and figure this out. There's some non-modifiable risk and there's some things that we can change. The non-modifiable first is age. So in general, as we age in the population, there's more chances of coronary heart disease, partly because it takes years to develop in the blood vessels and to become evident. There can be some gender differences, particularly earlier in our life. Men have a higher rate of cardiovascular deaths than women, but later in life, actually men and women, the rates actually become more equal. Family history of coronary artery disease also puts us at risk. And then there's also the genetic influence there. And I put question mark about non-modifiable, but now it looks like that some of the things that we're doing with lifestyle, diet, nutrition, exercise may be modifying our genetic expression. So we may not be locked into that as much as we used to think. So this year's annual scientific meeting with the American College of Cardiology, there are a couple of very interesting presentations that really make us more in tune to what's going on and addressing our health issues earlier than later. So they're finding that there's more and more heart attacks occurring at younger age. And so younger being below the age of 50, but actually there's a group where there's increasing about 2% a year for the very young age, under 40, over the last 10 years. So this is very interesting. So the age-related risk factor looks like it's shifting downward. The sort of corollary study that goes along with this is the one looking at diabetes. So more of those people in the younger age group actually have diabetes. So diabetes is really fuel for the fire. Another very important aspect of a proactive approach to vascular health and wellness. Also, they found that if someone has diabetes, then they're more likely to die. They're not as in good a health. They don't have as good cellular reserve than the people who have good glucose control. Modifiable risk factors. So this is where our efforts are going to be, and we can make a significant impact. And this is where 90% of the risk lies. So it has to do with good blood pressure control, our LDL cholesterol, things like smoking and diabetes and being overweight, all are huge modifiable risk factors that could go along with this. Poor nutrition, physical inactivity, excessive alcohol use, and then even our constant stress and lifestyle goes along with increasing our cardiovascular risk. So looking at some of the typical diagnostic modalities, of course, EKG, Holter monitoring for monitoring your heart monitor rate. Echocardiogram looks at ultrasound of the heart and heart function. Now we can do cardiac CT scans. We can get something called a coronary calcium score that can indicate some risk, and even do magnetic resonance or MRI scanning there. If someone has a higher risk or symptomatic, then they may even go ahead and get a stress test, or even go to cardiac catheterization to shoot dye in the vessels to take a look. The last three I put on here are actually non-invasive ways that we can get a very early look at cardiovascular risk that's over and above some of your standard risk factors that we looked at, such as cholesterol and diabetes and obesity. Carotid ultrasound, looking for CIMT, that's carotid intimal thickness. So we can actually assess additional cardiovascular risk with looking at the thickness of the carotid artery, and certainly in comparison to the average for age. This can be discovered even in people that are asymptomatic and have no other known risk factors to assess their cardiovascular risk. The next one on this list is the VO2 Max test. It's actually looking at your fitness level. So there's been some great correlations with that and cardiovascular risk, overall health and wellness, and mortality. And then the final is actually assessing the body composition and bone density analysis with the DEXA scan testing. So the carotid ultrasound, there's some studies that show that even in asymptomatic patients without known disease, that this assessment with carotid thickness or even plaque is more likely to raise their risk score that are using conventional measures of coronary artery risk, even more so than compared to that coronary artery CT scan looking at a calcium score. So the prognostic value of looking at the subclinical atherosclerosis, the silent disease, is greater than looking at all the other risk factors like cholesterol, lipids, blood pressure, diabetes, smoking, and BMI. VO2 Max, it's our exercise test that we do with every elite health evaluation. And it's looking at our abilities, our body's ability to transport oxygen during physical activity. And the VO2 Max is our maximal uptake during exercise. And so the greater the VO2 Max, the better your cardiovascular or cardiorespiratory fitness. It's been well correlated that low levels of fitness associate with high risk for cardiovascular disease and even mortality. It is actually a stronger predictor of mortality than some of the other risk factors like smoking or hypertension or cholesterol. The good news is that if we improve the cardiorespiratory fitness, we actually reduce mortality, and that you can reduce this with some marginal effort. So taking the lowest risk group, the lowest fit level, just to the next level, significantly reduce all-cause mortality. So you don't have to be a marathon runner or run an Ironman. You just need to raise your current level of fitness with a graduated plan. So our treatment modalities really should start with the lifestyle changes that include diet, exercise, stress management, weight management, and then modulating the three common pathways for cardiovascular disease: inflammation, oxidation, and immune reaction. The next level would be medications to control these other risk factors if it's not controlled with the lifestyle changes. And then finally, once you're getting into the secondary stages, you may need a medical procedure to open up the blood vessels and provide relief for blood flow. So some very good studies looking at the proof for primary prevention. So the American Heart Association lists statistics that 84% reduction just with dietary, cardiovascular exercise, avoidance of tobacco, and moderating our alcohol consumption. Pretty amazing. It can all be done without high technology or drugs. The American College of Cardiology actually published a paper looking at the dietary impact on cardiovascular health and risk reduction. I like this diagram as it starts out with something they call primordial prevention. So this is happening way before you might have expected some known risk factors, and it's all about improving the diet, controlling the excess calories, more like a Mediterranean diet if you look at what they explain, and they look for common reasons why this might not be happening in the population today. It's lack of awareness, lack of availability of high quality food, maybe the price of food, marketing, and taste and flavor. So these are all things how the food industry is positioning certain foods in society, and that's where the food choices are being made. Once people have ideas of cardiovascular risk, then we're looking at the primary prevention with diet, lifestyle, perhaps medication if these are available, and then secondary prevention has to do with helping to prevent recurrence once the disease exists. So I think they're doing a good job at explaining how we might, from a societal approach, reduce cardiovascular risk. Primary prevention. So I list some good examples of what we might look at for primary prevention, so before the disease exists. And these are all non-drug approaches to that and have good research that shows the efficacy. Garlic, for instance, definitely improves the lipids and also improves something called ox-LDL. So ox-LDL is one of the ugly molecules that gets stuck in the blood vessel and it gets over-oxidized and it becomes sticky and embeds itself in the endothelium. At that point, it creates this intense immune reaction. Garlic also prevents platelet aggregation, and it can lower the rates of coronary artery disease. Mediterranean diet, well studied for decades. The DASH diet, actually, healthy diet is probably controlling your sodium. Something as simple as omega-3 fatty acids has great antiplatelet activity, lowers triglycerides, and can actually help increase the good cholesterol, the HDL, and it's been shown in long-term studies to reduce cardiovascular disease events and death. So it has some outcome studies along with some of the drugs. There's some other lifestyle or non-drug approaches such as yoga, exercise, smoking cessation, and then of course doing weight control, significant reduction in cardiovascular risk just by controlling the BMI and keeping it at a healthy level below 25. Secondary prevention. So here's some examples of some non-drug ways of actually preventing recurrent heart attacks or recurrent cardiovascular events. Omega-3s. We know that after MI, it definitely prevents future cardiovascular events. CoQ10. They did a complete placebo comparison study. Definitely decreases cardiac deaths and events and non-fatal MIs. Even things like transcendental meditation and addressing spiritual well-being, these are all things that are involved in the stress reaction and the stress response that also has been shown to reduce blood pressure and even working through the cortisol mechanism for chronic stress reaction. So we're going to take a proactive preventive medicine approach, and that's our whole approach with the Cenegenics Elite Health Evaluation, the way we look at this. We want to look at the early predictive diagnostics. So we can go above and beyond and look at some advanced cholesterol markers, looking at particle numbers and size. These can give us some underlying risks that address something known as the residual risk or cholesterol gap. Half of all heart attacks have a fairly normal traditional cholesterol panel. If we look below that, we can see that many people have abnormalities in their particle numbers and size. We're also looking at some of the advanced metabolic markers. We want to look for signs of inflammatory activation, immune activation, and look further into their glucose metabolism and how tightly controlled their glucose is. Third in the list is micronutrient analysis. So there's been some clear association with nutritional deficiencies and cardiovascular disease and particularly hypertension. So we can get a full array and then address those and replenish those, and that helps for just healthier cellular activity. It's going to reduce oxidative stress, and it's going to control inflammation. We can also look at a set of cardiac genetic markers. And as I alluded to earlier in the talk, sometimes these markers we can influence, and we can change the expression. Actually, some very good nutrigenomic studies that we can change the expression with food. And then we want to look at the DEXA scan. We need to know specifics about our body composition. We need to know what is our fat distribution. Visceral fat, central truncal obesity is going to increase our risk. We also want to gauge what our changes in body composition are as we go through treatment to increase lean body mass and decrease fat mass. And we can do that via VO2 Max. We need to know cardiorespiratory fitness, directly correlated with cardiovascular risk and mortality. And finally, looking at the CIMT, another non-invasive way, gives a good assessment of cardiovascular risk, even in the asymptomatic patient, or even in the patient who may have few known risk factors. So when we get to the end of this evaluation, we're going to create a individualized plan that's going to include specific instructions for nutrition, lifestyle, stress management, integrative medicine approach, where we're going to use the non-drug approach to improve cardiovascular parameters like your omega-3s, addressing nutritional deficiencies. Going to give it individualized. So by utilizing our VO2 Max, we can actually define exactly where their fitness level is, but we also define where the target exercise zones need to be for both safe and effective exercise programs for fitness as well as weight reduction, which also can improve the cholesterol profile. And then finally, we're going to look closely at the metabolic hormonal balance. Clear studies show that if we have tighter regulation of our inflammation, our blood sugar control, and especially hormonal balance, that we're greatly reducing our risk for cardiovascular events in both men and women. It's a very key play and also an important area of expertise with the Cenegenics program. So, in short, change your life, change your food for health. We can take control of it, and we definitely have the tools to do this in a very proactive and interventional way to improve cardiovascular risk. That's the conclusion there. Be happy to entertain any questions you may have about presentation or cardiovascular health.
All right, thanks a lot, Dr. Flowers. This is really good information. If anybody has any questions, you can tap on the question icon down below and write those in. Okay, looks like we've already got something here. Got a question here that says, how early should somebody get tested for cardiovascular risk?
Yes, so as this recent presentation from the American College, even in the 40s that we're looking at that, certainly as an adult, we should probably have a cholesterol panel done at least once as an adult, and then, some of the recommendations are, maybe every 5 years. Sort of the joke among the cardiologists when we ask the question, when does cardiovascular disease start? And their answer is when we're born. So even in teenage patients post-mortem, they're already finding fatty streaks in the aorta. So many times this process is already starting earlier in life. And so if we look at before 40 age that's increasing their cardiovascular events by 2% a year, I would say certainly, by the time we're 40, but there may be times when we're younger that we should be looking at that. The jury's kind of out on that, but it looks like it's going to be early and earlier when we should be looking at that.
Okay. Another person's asking, if someone has already experienced a cardiac event, how does your program work with this to prevent an additional event?
Great question. So that kind of goes back to the secondary prevention sort of mode. And so, of course, we like to be on the front end of that, but once that's happened, there's some clear studies that show that survival after a cardiovascular event and decrease in recurrence depends on several things. Still weight control, still control of inflammation, oxidation, omega-3s, CoQ10, things like magnesium. And then there's a couple of interesting studies looking at hormonal balance, particularly in men looking at testosterone and thyroid. So there's some studies that show that if those aren't corrected, that those patients had higher rates of recurrence and sooner mortality than the people that had all of those things balanced. And so there's a way to do that and dovetail when people are still on medication, have additive effect to reduce their current.
Okay. Also, in the comprehensive blood draw that you mentioned earlier, are there any biomarkers that can be indicative of cardiovascular disease? Is that something that can be spotted through that?
Yes, so we're looking for the risk factors with the cholesterol. We're also looking at inflammatory markers as well. We measure a metabolic risk marker called homocysteine. And then the advanced cardiovascular markers, we can actually look deeper at other inflammatory markers that are actually more specific to vascular inflammation. So there are ways that we can drill down and get more specific of where the risk is. And then, of course, we combine that with the carotid ultrasound too. That could also be another indication that makes that a much more sensitive test when we look at all the data combined.
Okay. And someone wants to know, do you work with my family doctor and cardiologist?
Absolutely. And so everything that we do, at the end of the elite evaluation, you get all of your data together. And so even before the evaluation, we want to know everything you're taking, all of your health events, your health history, so that we can take that into consideration as we're putting the plan together. And then we want to make all that information available to you and your doctor. So we absolutely would work with the doctors. Yeah.
Okay. If I sign up for Cenegenics testing and diagnostics, how often do I have to retest?
So typically the full evaluation would occur on an annual basis. And you can also do parts of this on a quarterly or biannual basis. Particularly the DEXA scan would be the most popular study to do, where we're looking at body composition. And then blood work is actually done on a quarterly or biannual basis as well. So we want to mark our progress and look how we're progressing, and we can make adjustments to the program as we go.
Okay. Also another one, are there some simple steps I can take to reduce my risk factors and increase my cardiovascular health?
Absolutely. So like the American Heart study showed, it's nutrition. So we can control many risk factors by doing more of a Mediterranean-based diet. And so it's a lower carb diet, fruits, vegetables, olive oils, and also controlling the amount that we eat. So calorie control is important, that we're matching what our calorie burn is. So that's really one of the first places to start.
Yeah, diet plays a big role. Do you offer a program specifically for heart health?
So all the programs with the initial evaluation are all looking at cardiovascular health, because this is really at the forefront for what's going to help with our overall health, wellness, and longevity. And there are some advanced cardiovascular markers and other specific testing that we can do kind of based on specific risk markers or family history that we can do in addition to.
Right. Looks like I went through all the questions here. I'm not seeing any more up here, so I guess that's it. Really thank you for your time. Really appreciate it. Hope everyone was able to get some good information on that. And
very good. Thanks so much. Are there any questions or anything you want to contact us directly? Information is on the last slide, and we're happy to help you in any way. We can do a confidential discussion on the phone if you have any specific questions about your health, and we'll be happy to talk to you and help you in any way we could.
All right. Thank you. All right. See you, everyone.
Thanks so much.
Thank you. Bye.
Have a great day.